Hey everyone, it's Jamie Bass, your instructor for AMP2. We're going to continue on with lung physiology. This is the second part of the lung physiology lecture. I apologize for the end of the last video. It looked like my internet kicked me off, so hopefully there wasn't any issues with that last video. I have to go back and check that out. Let's continue. Let me go to screen share, and this is right where we left off. We were talking about Boyle's Law. Let's talk about some of the respiratory muscles that are involved in that expansion and contraction of the rib cage. We have inspiratory muscles, which are involved in the inhalation process, and expiratory muscles, which are involved in the exhalation. The primary muscles for inspiration, are the muscles that are involved in quiet breathing. So let me backtrack just a second and say that the process of inhalation is an active process. Your muscles have to contract in order for this to happen. And it's something that's controlled by some centers of the brain within the pons and medulla oblongata. So every time you're inhaling, those centers have to be activated to tell those specific muscles to contract. As those muscles contract, it elevates the rib cage, and then those muscles relax, and that allows for passive exhalation. So exhalation is a passive process. It's just the relaxing of those muscles. Inspiration is active. It requires muscles. So our primary inspiratory muscles that are used during quiet breathing right now, unless you're out of breath as you're watching this process, or unless you're hyperventilating or taking deep breaths or something like that, you have your diaphragm, which is 75% of the movement. The majority of the movement of our rib cage and thoracic cavity is our diaphragm. The diaphragm sits like an umbrella right underneath of our rib cage, and what's happening when it contracts is it depresses. It goes down into the abdomen. That's going to allow the thoracic cavity to expand, allowing for that decrease in pressure and therefore movement of air inwards. The external intercostals are those little diagonal muscles that are in between your ribs. And when they contract, they're shortening the space in between your ribs, which is going to pull your rib cage up and elevate it. So you have your external intercostals pushing your rib cage up and your diaphragm pushing down, all allowing for this increase in volume in the thoracic cavity. There are some accessory inspiratory muscles. These are going to be activated in times of, like if I were to ask you to, okay, everyone, take a deep breath right now, right? Then you're activating your inspiratory muscles. It's giving you a deeper breath. It's increasing the speed that you're inhaling, right? So these can also be activated when the oxygen demands are not being met by just quiet breathing. Sternocleidomastoid pulling up on your clavicle and first rib. The scalenes, again, pulling up on your clavicle. Pectoralis minor, pulling your rib cage up. Serratus anterior, again, pulling and elevating your rib cage up. So all of these smaller muscles are there to help elevate the rib cage and help speed the, or help increase the speed of inhalation. So here you see all of those muscles in case you don't remember from last semester. Hopefully you remembered a little bit of them, where they're located. There's a different view for you. So those respiratory muscles are important in inspiration. As I said, there are no muscles that are used during passive exhalation. It's just a relaxation of those inspiratory muscles. It's just those elastic forces and gravity pushing your rib cage back down, allowing the diaphragm to pop back up into its umbrella shape. However, there are accessory expiratory muscles. If I ask you to exhale completely or take a deep breath and then push all the air out as fast as you can, what's going to be activated then are some other muscles, like your internal intercostals, your transverse thoracics, external obliques, rectus abdominis, internal obliques. Your abs are going to push in your abdomen, which is pushing that diaphragm up, which is pushing that air out of your lungs. So it's all helping to depress the ribs and push the diaphragm back up into place. It's assisting in decreasing the thoracic volume very quickly, which is going to increase the thoracic pressure, which is going to push all that air right back out. There are those muscles that I just mentioned. There's the side view. So let's talk about some respiratory volumes. I already mentioned tidal volume briefly. Tidal volume, abbreviated V, little t, is the amount of air that's being exchanged during every cycle of breathing, during your resting breathing, when you're walking, talking, living your life. It's about 500 milliliters, whether you're a male or a female. It's just about the same. Now, let me say something, because there's always this question, do you have to know the values? Yes. For these numbers, you have to know the values. You're going to have a lab quiz when in lab class on these values, and you may also see them on your exam. So it's important for you to be familiar with these values. The inspiratory reserve volume. This is the amount of air that you can breathe into your lungs above the tidal volume. So you've already breathed in your 500 milliliters. How much more can you suck into your lungs, right? Expiratory reserve volume. You've already breathed out your 500 milliliters. How much more can you push out without having to inhale even more, right? The residual volume is the amount of air that's left in your lungs even after you've pushed it all out. So after you've had your expiratory reserve volume, you've gotten rid of all the air in your lungs, there's still some left in there that your body's not going to allow you to exhale. It's called your residual volume. Your minimal volume is the amount of air in the lungs that may be collapsed. This can't actually be measured in a healthy person. This would only be measured in someone who has a major injury. So let's talk about capacities. Those were just volumes. Now let's talk about capacities. There's something called your inspiratory capacity. This makes sense. This is how much air you can inhale, which is your tidal volume and your inspiratory reserve volume. Your vital capacity, this is the range that you can breathe in and breathe out. So this is your expiratory reserve volume, your tidal volume, and your inspiratory reserve volume. Your functional residual capacity is how much you can push out, your ERV, and your residual volume. So it's how much is left over after you've done your tidal volume exhalation. And then your total lung capacity is your vital capacity, how much air you exchange in a forceful inhalation, exhalation, and your residual volume. This is basically how much air your lungs can hold at any given time. So here's the graph. Remember I said this was going to look a lot like cardiovascular physiology? Here we see it again. Almost looks like an EKG, right? Hopefully it doesn't. So this up and down is your tidal volume. If we start all the way over here at the left, our tidal volume is just 500 in and out, in and out. Then the doctor says, okay, after you exhale, now see if you can push all that air out. That's your expiratory reserve volume, the difference between what you exhale normally and what you can also push out of your lungs forcefully. Then you go back to tidal breathing, one little cycle. And now take a deep breath and blow it all out. What you just did was your vital capacity. Don't get dizzy on me. Bring it all in, push it all out. That extra that you can inhale above your normal tidal volume is your inspiratory reserve volume. That's how much extra you can breathe in. Then how much extra you can breathe out is your expiratory reserve volume. All of that put together is your vital capacity. Notice you never get below your residual volume. That residual volume always stays in there. It's around 1,200 milliliters for everybody. Your functional residual capacity is how much extra you can push out plus that residual volume. So this graph shows you all of those values. If I gave this graph to you on a test quiz or lab quiz and ask you, what these different sections of the graph were, you should be able to tell me what they are and what their relative volumes are. Notice our total functional lung capacity or total lung capacity is around 6,000 milliliters of air, or 6 liters of air. That's a lot. If you think about a 2-liter bottle, there's 3 of them. It's a lot, right? And notice that our lungs typically have around 2,000 milliliters in them at any given time. It's just going up or down depending on which part of our breathing cycle we're in. So here's some volumes. Notice the differences between males and females. And again, these volumes will come at you maybe in a test or quiz, as well as perhaps in a lab quiz. So you should be familiar with females versus males. Obviously, males are always a little larger in their capacities. Their thoracic cavity is larger, so therefore they're going to have more space, and their lungs are going to be bigger in general. Not always, but these are always average numbers. Obviously, a smaller person is going to have smaller volumes, a larger person is going to have larger volumes. You can pause the video here, go back and review this section. We'll keep going and talk about pulmonary ventilation adjustments, because while that's all nice to know about our tidal volume and inspiratory and expiratory reserve volume, obviously we adjust those according to our metabolic needs. So there's two things that are going to basically determine this. One is the rate and one is the volume. Kind of like cardiac output, right? Cardiac output was a measurement of our stroke volume and heart rate. Stroke volume was how much is being pushed out, and rate is, the beats per minute. It's the same thing here with pulmonary ventilation rates. You have your respiration rate, which is how many breaths are in each minute. On average, it's 12 to 18 breaths per minute, a little bit higher in children. They're smaller, right? Higher metabolism. The tidal volume is how much is moving in and out, just like our stroke volume. So kind of a neat similarity between the two. And here you see that tidal volume, inhalation, exhalation, inhalation, exhalation. Notice this is time in seconds. So we have something called our respiratory minute volume, or VE. This is the volume of air that's moved in and out of the lungs per minute. So this is equal to your breaths per minute times your tidal volume. So in other words, this is kind of like your cardiac output. This is how frequent are you breathing and how much are you breathing in, right? Your tidal volume should always be around 500, right? There's a slight variation that could affect either factor, which could determine your ventilation minute volume or your respiratory minute volume. And at rest, this is typically around 6 liters per minute, as I mentioned before. So just showing you how to do the math. I promise any math I give you on a test quiz or lab quiz will be super straightforward. So respiratory rate, tidal volume determines your respiratory minute volume. So let's talk about another term. There's a lot of terms here, a lot of volumes, a lot of capacities, a lot of rates, and it's just going to keep adding up. So if you're feeling like these terms are getting overwhelming, stop the video here, go back and review what we've already talked about. Master that before you start adding new words into your word bank in your head, right? You have to master what we've done already before you can add more to it. So make sure you understand everything we've covered already. Alveolar ventilation. VA. This is the amount of air reaching the alveoli. This is not the same as our tidal volume, because just because we're breathing in 500 milliliters of air does not mean that 500 milliliters of air are getting to our alveoli. And this is because there is conducting portions of our respiratory system that do not exchange gas with our blood capillaries. That's called the anatomic dead space, or VD. Sounds kind of morbid. It's the anatomic dead space within our respiratory system. This is where no exchange is taking place. It's on average around 150 milliliters of air. Air capacity, I guess you would say. So the air that's reaching the alveoli is actually a mix of used air and air that has been freshly exhaled, because that air that was sitting in that in that dead space is then passed down or passed out, and there's this mix. It's not like a one-way street, right? Your conducting passageways are two-way streets, letting stuff in and out of the lungs. So sometimes you're inhaling the stuff that you're just trying to exhale. So in that case, less oxygen and more carbon dioxide in the alveolar space than when we compare it to the atmospheric air. It's more concentrated in our alveoli because of this mixing that occurs in that dead space area. That's our alveolar ventilation rate, or our VA. So here you can see that anatomic dead space portion and then the air that's in the actual alveoli. You can see how that would vary, correct? So with that alveolar ventilation, you're going to calculate that as breaths per minute multiplied by the actual volume of air in the alveoli. How do we determine the alveolar air? Well, you have your tidal volume minus your anatomic dead space. So roughly, tidal volume is 500, anatomic dead space is 150, right? So that should be about the same for everyone. Very small changes in tidal volume can have a larger effect on your alveolar ventilation. When the demand for oxygen is increasing, both your tidal volume and your respiration rate have to increase in order to increase your alveolar ventilation. So this is just showing you like some numbers to give you an idea. So you have your alveolar ventilation frequency times your tidal volume minus anatomic dead space. On average, 500 minus 150, you're going to get about 350. So if your breaths per minute are 12, 12 times 350 gives you 4,200 milliliters is your alveolar ventilation. That's how much air is actually getting into the alveoli and being exchanged per minute. I'm going to stop the video here so you have a chance to digest all of this material, go back, review, and answer these 3 questions. Familiarize yourself with that important vocabulary before we move on to more complex stuff. All right, see ya. Bye.